Thank you very much for the honor to present here today for the second annual KOVAS presentation. I've been welcomed with open arms and am grateful for the fantastic hospitality you all have provided us. Today I'm going to be talking about something that I'm quite passionate about, cardiac rehabilitation. And today my main focus is going to be three areas. I'll be updating you all on what we have updated on the American Heart Association's core components of cardiac rehabilitation. We'll have a special focus on frailty and what cardiac rehab's role is in that population. And then we'll finish off with the use of technology and the future use of technology in this area. Now, starting in 2007, the core components of cardiac rehabilitation were published by the American Heart Association. Typically, when we think cardiac rehab, we think exercise. And certainly, exercise is a major component of cardiac rehabilitation, but is also comprised of attention that is placed to other aspects of secondary prevention. Nutritional counseling and exercise are utilized to be able to help manage weight, blood pressure, lipid, diabetes, focusing on tobacco cessation, as well as the psychological management of going through a cardiac event and potentially life-threatening event, in addition to counseling physical activity. Now, it has been a while since the update has happened, but recently in 2024, we have updated the core components of cardiac rehabilitation, published in Circulation, as well as the Journal of Cardiovascular and Pulmonary Rehabilitation. In this figure, what you can see is a focus on the patient assessment of physical activity, dietary habits, etc. We'll also be focusing on the delivery method of cardiac rehab. We're very used to having a center-based program, but now with the advent of various technologies, we're able to reach our patients outside of the hospital and in their homes or in their exercise facilities to help improve their health. And as eloquently demonstrated in Dr. J's presentation, cardiac rehabilitation is quite impactful in improving health, extending lifestyle or lifespan, and improving health span. And we do this by focusing on the major components of cardiac rehabilitation. And in this edition, we have put a special emphasis on strength training, body composition, and assessing program quality. These are the three that I'll be focusing in this portion of the presentation. We'll look at the evaluation, the intervention, and the outcomes we should be mindful about in these three areas. Specifically with weight management, we have to have some type of assessment of body composition. Now, we can all do body mass index quite easily, but this is not a very specific assessment of body composition. We do have other tools, such as measuring skin folds, that are very simple and affordable, and it gives us an idea of some fat mass composition. But again, this could lack precision, and it could lack accuracy. As easy and low cost that waist circumference and hip circumference is, it gives us a pretty good idea of where the fat is being distributed across the body. And so this provides us a moderate accuracy for body fat and trying to target various areas in the body to help reduce that through various lifestyle interventions. And of course, not too many programs have access to body composition scans, but if you do, this is a phenomenal way to be able to get an assessment of fat mass, lean mass, and bone mineral density, which is quite important when we're looking at older individuals, particularly females, who are in the menopause transition. As far as the intervention goes, when we're working with weight management and body composition, there's various things that we would be able to implement. Certainly performing nutritional improvements in individuals' diets. High-intensity interval training is quite effective in increasing muscle mass in some individuals that have low muscle mass through aerobic styles of exercise, but also help facilitate weight loss. In many of these patients that have been obese or morbidly obese for many years, they have the disease of obesity, and this truly changes the way in which their adipocytes are functioning. And unfortunately, weight loss and weight loss maintenance is quite difficult, but with the advent of various medications, that can certainly help facilitate the loss of weight, in addition to various surgeries that can help lower body fat mass. The thing that we have to be aware of is the lean mass. What is that rapid weight loss and lower calorie intake doing to muscle quality and muscle function? And we can certainly use exercise as medicine to be able to target that. As far as our goals go, our primary goal with weight management and composition, improvement in body composition by decreasing body fat or increasing lean body mass. And the secondary goal, optimal levels of body composition, would include larger proportions of lean mass for those individuals. Now, how do you accomplish this? This is going to be done through resistance training in many cases, and so we'll have a special focus on this. As far as the evaluation goes, the AHA guidelines are the scientific statements. So we look at the literature, we look at the science to tell us what is gold standard. And with that, it is measuring 1 rep maximal efforts. This can be quite difficult in some of our patient populations because they're not familiar with exercise. So performing multiple repetition tests will give us a really good idea of the strength that these individuals have. It's vital to perform familiarization with the types of modalities that they will be exercising on, performing a warm-up to make sure that the muscle is ready to contract at full maximal effort, performing 4 trials with 3 to 5 minutes of rest in between to facilitate a good amount of recovery to give a full effort with the subsequent contraction, and then trying to reach 50 to 70% of their perceived capacity and gradually increasing the weight with those 4 trials by 5 to 10% in the upper body, 10 to 20% in the lower body, and then performing a full range of motion, and then the final weight successfully recorded would be the 1 rep max test. The intervention, of course, is in theory quite simple. 2 to 3 non-consecutive days per week for the frequency, intensity 10 to 15 repetitions, 40 to 60% of 1 rep max, and then a moderate to vigorous intensity 11 to 13 on the 6 to 20 Borg scale. In many instances in practice, it's difficult to do a 1 rep max test. So what we're trying to achieve is close to failure with those repetitions once you're getting to about 10 repetitions. This gives us a pretty good confidence that they are at the intensity that we would want to closely mimic the scientific statements. As far as time, we're looking at 1 to 3 sets. In individuals who have never done any type of resistance training, 1 set is adequate to start to see some improvements in muscle strength. And we also want to target multiple different body parts, 8 to 10 exercises, and trying to target the lower body first and then working your way up to smaller muscle masses to make it more feasible to complete that session. And really, you can use anything, machines, free weights, bands, body weight, the muscle does not care. As long as you give an adequate stimulus, you're going to start to see some improvements in muscle strength and size. As far as goals go, we're trying to prevent or reverse frailty and reduce the risks of falls. So we need to understand where they are in terms of their fall risk. A few tests you could use, a timed up and go or a tug test, where you're trying to go from a seated position to standing, walking around a cone placed 3 meters out and then sitting back down, and trying to complete that under 12 seconds so that you would not be at risk for falling. The 30-second chair stand is another fantastic and affordable way of testing muscle power. And then the 4-stage balance test in putting your feet in various positions. And if the individual is not able to complete 10 seconds in this tandem stance, that puts them at an increased risk for fall. So balance is certainly an area that we would like to focus. And you can look at the medical records of that individual, or you can ask them the Berg Balance questionnaire to get an assessment of how many of those risk factors that they have, such that if they have lower scores, that's going to be wheelchair bound, 21 to 40, walking with assistance with canes, and then if they're above 40, then they would be independent. And this is what we're truly striving for when we deliver these interventions. As far as performance measures, the last segment of this first segment, we certainly want to understand if our patients are improving cardiorespiratory fitness. We do this affordably using the 6-minute walk test. understanding how the patients have done in the different core components of cardiac rehab is absolutely vital. And that tells us if we are providing the correct medicine, the correct interventions, to be able to help reverse all the deleterious effects of cardiovascular disease. We're also putting a special emphasis in the guidelines with the programmatic performance measures. What are the referral rates? If a patient has a qualifying diagnosis, are they going to cardiac rehab? Is the doctor saying you should go? From those individuals, how many actually enroll and attend? How many sessions are they doing? And how many of those individuals are completing the program? If we're starting to see that these numbers are low on this side, we need to come up with ways of getting patients into these programs. If adherence is difficult, are there distance travel issues? Are there things that the program can do to help keep patients into the program? Really helps us understand which areas we need to focus on. Now, a big topic in the cardiac rehab world is treating frailty. We can certainly appreciate that with age, physical activity, physical health, muscle function, muscle strength, cardiorespiratory fitness is going to decline. This is a known fact. This has been documented. However, if we exercise and if we take care of our bodies, we're going to start to slow the progression of that loss. Individuals who are physically inactive, have multiple risk factors for cardiovascular disease, ultimately end up developing cardiovascular disease, coronary artery disease. In this case, we are doing, or the doctors are doing, a fantastic job of keeping patients alive. There was a time where if someone had a heart attack, there was a 50% chance that they would survive. Nowadays, upwards of 90%. If you have your first heart attack, there's a decent chance you are going to live. Now, with that, if you are not performing healthy activities of daily living, you're going to accelerate that aging process. And both of these, aging as well as cardiovascular disease, are going to increase the risk of frailty. And of course, when someone becomes frail, physical activity goes down, muscle strength, quality, etc. goes down, and that further accelerates the aging process. So we need to intervene. Traditional cardiac rehabilitation, at least in the United States, has been done in a cookie-cutter fashion. Regardless of what the patient's diagnosis, they're going to do the same exact intervention. And I referenced before that exercise is medicine. If you have a disease, you want the right medicine. If you have various physical conditions, you want the correct exercise medicine to treat that. And unfortunately, in many cardiac rehabilitation programs, the main focus is aerobic exercise for everybody. Now, wait a second, I thought aerobic exercise was good for people. It certainly is, absolutely. The data is unequivocal. You look at group-based studies, aerobic exercise helps in so many ways. But when you focus on frail individuals, they don't really need the aerobic exercise first. They need to focus on the strength training, and multiple studies have shown that the majority of exercise sessions are aerobic, with maybe 10 minutes to resistance training, which is not enough. And if we look at the literature to support this idea and this concept, we can look to work by Phil Ades, unfortunately late Phil Ades, who is a legend within our field, took disabled female cardiac patients over the age of 64, and they did high-intensity resistance training, so 80% of 1 rep max. If anyone has ever done that, that is a very difficult intervention. And then the other group was randomized to light yoga for control. Those that had the high intensity were able to show greater improvements in activities of daily living, such as simulated grocery carrying, lifting heavier luggage onto a bus, and, believe it or not, they improved endurance, cardiorespiratory fitness by just doing resistance training. So at these low levels, we can use resistance training to help improve cardiorespiratory fitness. Moving on to another study where they looked at aerobic exercise, resistance training as a part of multimodal exercise versus traditional aerobic exercise. Those in the multimodal experienced a 63% improvement in physical function compared to 33% in the aerobic exercise. Only 1% in multimodal experienced a worsening of physical activity, and 21% experienced a worsening of physical function in the aerobic exercise group. Further evidence, when we're implementing these styles of training with exercise, with aerobic and resistance, we're seeing significant improvements in 6-minute walk test distance, timed up and go, gait speed, hand grip strength, patients who were frail and lower absolute values, but had greatest relative improvements, and that's quite meaningful. 50 patients improved their frailty status, 15 patients worsened, and 178 remained the same in this study. So this is indicating that there could be room for improvement, a greater emphasis on resistance training. And so generally, when we work with frail individuals, first main interest is resistance training, gradually increasing aerobic exercise, and then gradually splitting time between the two. And a wonderful study that supports this concept is a recently published multi-site trial called the Rehab-HF trial. And the way they determined where a person's time would be spent is identifying their level of frailty. Level 1 would be the most frail, all the way up to level 4, which is pretty self-sufficient. And they categorize this in different areas of strength, balance, endurance, and mobility. And at the lower levels of physical function, 75% of the session was for strength, balance, and mobility exercise, with only about 25% to endurance. As they saw improvements in functional level, the amount of time went to endurance went about 50%, and then the remaining 50 was spent on the strength, balance, and mobility, but a very little amount of time with balance and mobility by the end. The important thing to take from this graph is that strength training remained consistent at 30% of the session. So this remains a very important part, even when functional levels are quite low. And these are references to the different exercises that one would do in the various levels, but essentially focusing on lower body strength, various balance exercises, continuous walking at different time intervals, and then performing different mobility exercises. And I'll conclude here with the mobile health. We need to understand the different ways we can combine cardiac rehabilitation programs. With synchronous real-time, we have patient exercises at home while monitored by the clinician in real time using technology. In synchronous in-person, that's patient exercises with clinician at same location. And then asynchronous is patient exercises independently, and the clinician reviews their data and provides feedback at a different time. And a hybrid model would integrate 2 or 3 of these at a time to best facilitate the adoption of activity. And in this study right here, they compared individuals that were randomized to an in-person intervention, a virtual intervention, and then a combination of the two. When you total up the number of sessions within both, there were no significant differences. But when you're looking at the 6-minute walk test, blood pressure at the end, systolic and diastolic, as well as weight loss, no significant differences across the 3. Usually we want to hear there's a significant difference, but in this case, a non-significant difference is great, meaning that an individual can do mobile health, cardiac rehab, and get the same outcomes as an individual who goes into the gym and exercises with those practitioners. So there are many areas of advantages, gaps, and challenges left in this as it is relatively new. And advantages, it could be quite flexible. Adherence is great. Diversity of technology allows individuals to perform exercises at different places. Quite effective, and you can increase the size that this is reaching out to. You also have gaps and challenges that many of you, I think, are in a good spot to look into and make sure that this type of technology is accessible to all patients and individuals. We recently got a publication in Lancet where we're looking at the effectiveness of home-based cardiac rehab interventions delivered via mHealth, and we saw that they were compared with usual care non-cardiac rehab. mHealth home-based cardiac rehab significantly improved 6-minute walk test and VO2 peak. No significant differences were found between mHealth and center-based cardiac rehab. Quality of evidence ranged from low to very low across outcomes due to risk of bias and small sample size. But again, the same story, non-inferior. You're getting the same outcomes as you would if you were in the facility. So wrapping up here with future directions, we need to explore the optimal duration of in-person synchronous cardiac rehab when delivered as part of hybrid programs. The optimal combination of delivery models remains an unanswered question in an area that I believe many of you would be able to help answer. And lastly, the takeaways: from the whole presentation today, there's a greater emphasis on high-quality performance measures that we need to focus on. Many patients with cardiovascular disease are at an increased risk of frailty, and a multidimensional intervention is needed. And then there are too many patients qualifying for cardiac rehab to accommodate the center-based programs, so we have to use technology to see these patients. Thank you for your attention, and looking forward to answering questions at the end.